we ask the ICAP students, the interns to turn on the cameras?
Yeah, I believe they have their cameras on. If you feel comfortable, please. Okay, I think let's get started. So my name is Alea Khalifa. I am a doctoral student in the epidemiology department, and I'm also a pre-doctoral fellow in ICAP's Global HIV Implementation Science training program. So in today's session, students will have 4 minutes in total to present. That way we'll have at least a minute to answer questions, maybe a little bit more per student. And I'll give you a 1-minute warning in your presentation, so you know when you need to start wrapping up, and we can open it up for questions when you're done. After the Q&A is complete, I'll thank you and we'll move on to the next person. And we also have a 4th student presentation that will play by video today since she couldn't make it in person. Finally, I'll just ask that all the participants stay on mute. And when we open it up for questions, feel free to unmute or write in the chat. I can help moderate the chat. Okay, let's get started. Nidhi, would you like to start again this time?
Sure, I'll go ahead and share my screen.
Okay.
Can you all see this? Okay, cool. So hi everyone, my name is Nidhi Patel, and I did my practicum over the summer at ICAP, but I was working remotely from Massachusetts, and my point of contact was my mentor, Madeline Goodman, who is a data manager at ICAP's Harlem Prevention Center. And together we worked to assess how the demographics and risk behaviors of those who enrolled in HIV prevention trials at HPC affected their pre-eligibility status for these trials. So we focused particularly on the recruitment of men who have sex with men and transgender women as our population of interest. And we performed a cross-sectional study using data that was collected from 2016 to 2021. Keeping in mind our objective to explore potential relationships between the characteristics of the study population and enrollment pre-eligibility for these trials. So those who were recruited were asked to self-report demographic information and risk factors for HIV, as well as to answer questions pertaining to pre-eligibility for trial enrollment. And after distinguishing those who were pre-eligible from those who were not, we conducted bivariate analyses using SAS and further logistic regression using Stata to assess the roles of demographics and risk factors on pre-eligibility. So just to briefly go over the main findings, in regards to demographics, the average age reported among the study population was 33 years, with the majority of participants identifying as white, Black, or Hispanic. And when compared to white participants, Black participants are found 47% more likely to screen pre-eligible, and Hispanic participants were found 79% more likely. And then in regards to risk factors for HIV, more than 95% of participants had responded with a no to engaging in condomless sex and stimulant drug use in the past 6 months, as well as responding with a no to having an STI in the past 6 months. So those who were engaging in condomless sex in the past 6 months were found 70% less likely to screen pre-eligible than those not engaging, and those who did have an STI in the past 6 months were found 78% less likely to screen pre-eligible than those who did not. Additionally, every 1% increase in sex partners in the past 6 months was found to be associated with a 5% increase in likelihood for pre-eligibility. So this result suggests that recruiting those who have a higher number of sex partners could potentially increase the odds of successful enrollment into HIV prevention trials that are conducted at HPC. And this was a key takeaway from the study, along with the fact that both demographics and HIV risk factors were found to significantly impact the pre-eligibility status for these trials. And lastly, I just want to thank the staff at HPC and the study participants for making this research possible, as well as thank my mentor, Madeline Goodman, for making my practicum and experience at ICAP so valuable. Thank you.
Thank you, Nidhi. We'll open it up for questions now. Feel free to unmute yourself. Okay. If there are no questions, then we can move on to the next student. Fantastic job, Nidhi. Thank you.
Sure. I'll stop sharing my screen.
Okay. Judy, can you go next?
Yes.
Okay.
Okay, can you see my screen? Okay, great. So hi everyone, my name is Judy Fordra and I was an intern with this program for the Strategic Information Unit. I worked with Dr. Maria Lorota and Lauren Parmley, who was my mentor on the formative assessment data for a upcoming or a continuing biobehavioral survey. So in Zambia, currently Zambia has a national HIV prevalence of 11.1% among adults aged 15 to 49 years, and an annual incidence of 6.6 per 1,000. And Zambia was actually one of the 8 countries that attained the 2020 90-90-90 fast track target set by the UN. There's currently a new target, the 2030 fast track 95-95-95 target, which is planning to address the addressing HIV around the world. And in order to address the HIV in Zambia, we need to focus on prevention, care, and treatment of key populations, which include people who inject drugs or PWID, men who have sex with men, MSM, and transgender women, TGW. That is because these populations normally have a higher risk of HIV acquisition. So this past summer, I explored the experiences of health service utilization, access to health information, and stigma, discrimination, and violence among PWID and MSM TGW in Zambia as part of a formative assessment for a biobehavioral survey. So we conducted in-depth interviews and focus group discussions with PWID and MSM/TGW across different cities in Zambia. We also conducted these interviews and focus group discussions with health service providers for the key populations, and all the interviews were conducted by a trained interviewer. Data collection occurred from November to December 2020, and the participants were recruited using snowball sampling. I was able to use the data from the interviews to do some coding and create some memos to pinpoint the main themes from the interviews, and then remove the notes to an Excel matrix for further qualitative analysis to identify and inform the required protocol modifications and the BBS logistics. Data was analyzed separately for the PWID and for the MSM-TGW, and we also were able to calculate some of the descriptive statistics. So in terms of the results, most of the PWID participants identified as males. Among the MSM/TGW, nearly 3/4 identified as male, while the remaining identified as TGW. Most PWID and MSM/TGW reported encountering non-key population-friendly staff at public health facilities. Some reported judgment and maltreatment by healthcare workers. Both populations reported avoiding visiting public facilities and preferred seeking care from private clinics and NGOs in order to avoid the healthcare worker stigma that they were facing. While some of the PWID service providers reported that current anti-drug laws impeded NGOs from providing reduction harm services, MSM/TGW service providers reported inconsistent use of HIV treatment services by this community due to the high mobility. Both populations also faced issues with community members. So PWID reported that community members often perceived them as violent and as criminals, while MSM/TGW reported that community members perceived them as abnormal and also experienced physical and/or verbal abuse by community members. So both PWID and MSM/TGW also expressed limiting interactions with police due to police aggression and police bias. And both populations reported experiencing employment termination or refusal of employment due to their drug use and sexuality, respectively. So based off of our research, we concluded that stigma mitigation interventions aimed at public facilities and community members may help key populations access health services, and it will also help foster a more enabling environment to improve the quality of the health services for both the PWID and MSM/TGW, and also improve access to harm reduction services for PWID specifically. I would like to thank my mentor, Lauren Parmley, even though she's no longer with ICAP. She was really great at involving me in all the things that we were doing with this project. And also Dr. Maria Lahuta for pushing me to try out qualitative research. So thank you.
Thank you, Judy. We have about a minute if anyone wants to ask any questions for Judy. Okay, I think we'll move on to the next student, but we might have some time at the end if you think of any questions that you'd like to follow up with the students on. All right, Kiana, take it away.
Hi, everyone. My name is Kiana Chan. I'm a second year MPH student in the Epi department. And this summer, I had the opportunity to work with Dr. Abigail Greenleaf, Monique Millington, Dr. Shannon Farley, and Andrea Lowe on the SILVER study, which stands for the SARS-CoV-2 impact on the lives and views of elderly residents. This study aims to understand and evaluate the impact of COVID-19 on community dwelling older adults age 70 plus in New York City. My particular project looked at telehealth usage by race and ethnicity among older New York City adults. A little bit of background on this study. The COVID-19 pandemic led to a rise in telehealth usage, showing telehealth as a valuable healthcare tool. However, the literature suggests that telehealth use disparities can reflect in-person health disparities with roots from systemic racism among Black and Latinx individuals. Since much of the literature on COVID-19 was focused more on morbidity and mortality, and few studies focused more on the social determinants of health related to COVID-19 among older adults, this study aims to examine the relationship between race and ethnicity and telehealth usage in our sample of older adults in New York City. We conducted a phone survey of older adults in New York City from December 2020 to March 2021 using random digit sampling, calling a list of landline phone numbers. Interviewers enrolled 676 participants with a 5% response rate. And we analyzed survey data using bivariate and multivariate logistic regression and odds ratios with 95% confidence intervals. Our results for this study, we conducted various regression models. Overall, we found that 44% of participants indicated having a doctor appointment by phone or video in the past 3 months. Among those who reported excellent health status, 36% reported telehealth usage compared to 62% of those who reported poor health status. In our adjusted regression model, which included demographics, internet, and health status, we found that compared to the reference group of white individuals, Blacks, African Americans had 2.14 times the odds of telehealth usage. Latinx individuals had 2.25 times the odds of telehealth usage, and those who identified as another race had 3.44 times the odds of telehealth usage compared to the white reference group. These findings were interesting and they were contrary to what we found in the literature because we found that people of color had higher rates of telehealth usage compared to the white reference group. And this relationship strengthened when we adjusted for health status and income in the model. So our next steps are to really dive in deeper and understand why we found that individuals of color had higher telehealth usage. One hypothesis that we have is looking at the interaction effects between health status and income to see if that influenced the relationship between telehealth race and telehealth usage. And so I really look forward to continuing this in my thesis work, and I thank the Silver team and ICAP for this opportunity to conduct this research. Thank you.
Thank you, Kiana. Do we have questions for Kiana? Okay. All right, well, we have a video presentation from a fourth student, Camille, which I will show now. And afterwards, we'll have a few minutes, I'm guessing, to ask any remaining questions anyone might have. So I will share my screen so you can view Camille's video.
Hello, everybody. Today I will be speaking to you about the impact of cyclones and COVID-19 on HIV and the health system in Mozambique. As we all know, climate change is increasingly posing a serious threat to public health and health systems around the world, including in Mozambique, where two devastating cyclones hit in 2019, followed closely by the COVID-19 pandemic. The aim of this study was to identify the strengths and gaps in the country's response to these emergencies, with a particular focus on the impacts on people living with chronic diseases like HIV, as well as lessons learned. We conducted a number of key informant interviews along with focus group discussions and an electronic questionnaire, but today I will focus on the interviews. There were a wide variety of perceptions and opinions on the health system response. These may be due to differences in location, occupation, or lived experiences during the cyclone and the pandemic. A majority of respondents praised the heroism of healthcare workers who provided crucial care despite damage to their homes, loss of loved ones, and a challenging work environment. Despite serious infrastructure damage, patients and healthcare workers alike felt that services were not disrupted thanks to strong international support as well as an existing differentiated service delivery system that allowed HIV patients to obtain 3 to 6 months worth of medications at a time. These same themes came up for the COVID-19 response as well. Healthcare workers made huge sacrifices to ensure continuity of care despite a lack of PPE, and the differentiated service delivery system made it easier for HIV patients to remain compliant to their treatment during the pandemic. Furthermore, many respondents praised the government for the low number of COVID deaths in Mozambique. There were several critiques of the health system's response to both the cyclones and the pandemic. Generally, a lack of preparedness and resources were serious issues in both of the emergencies. Next, it was often noted that the strong support from international NGOs and foreign governments was helpful but not sustainable. Also, rural and urban disparities and economic difficulties are existing issues in the country that were exacerbated by these two emergencies and made even worse by ongoing conflict in the north of the country, which has forced the displacement of thousands and restricted access to services. Overall, Mozambique responded quickly and effectively to the cyclones and the pandemic, considering the resources it had available. However, key informants had several recommendations. The most common one was the construction of resilient infrastructure that will not be damaged by future effects of climate change. A greater emphasis on community outreach and education on the impacts of climate change and infectious diseases with a focus on prevention is also needed. Finally, the Ministry of Health needs increased funding and responsibility to be able to prepare for and respond to health emergencies in a more sustainable and independent manner. We hope that the results of this study will be useful in preparing for and responding to the impacts of climate change, as well as any future health emergencies in a more robust, efficient, and sustainable way for Mozambique and similar countries around the world. Thank you, and I would also like to thank Dr. Andrea Lowe for her support throughout this project, as well as ICAP staff in New York and Mozambique, the Earth Institute, and the Ministry of Health in Mozambique. Thank you very much.
Okay, thanks to Camille for that. We have just about 3 or 4 minutes. If there are any remaining questions for the students, please go ahead and ask. Otherwise, we can rejoin the main session. Thank you.